Hello, my name is Mark Ball, and I would like to thank the Kidney Cancer Association and the organizing committee of the International Kidney Cancer Symposium for the opportunity to speak today about what I think is an important and sometimes overlooked topic in kidney cancer, and that is the management of multifocal non-clear cell RCC. I'm joining you today from the National Cancer Institute at the NIH in Bethesda, Maryland, where I'm a urologist. I have no disclosures. Multifocal renal cell carcinoma is defined in a few different ways in the literature, but the definition that's used most commonly, and the one that I'll use today, is when there is more than one renal tumor in the same kidney. RCC with multifocal involvement has been described in anywhere from 6 to upwards of 25% of cases. And there is a strong association with multifocality in bilateral renal cell carcinoma. In one study, synchronous bilateral RCC was reported. When it was reported, multifocality was found in over half of those patients. So if there was one tumor in each kidney, a kidney could have more than one tumor over half the time. On the other hand, at autopsy, the incidence of bilaterally is almost 90% once a multifocal RCC is present. There are several causes for multifocal RCC. Maybe the one we're most familiar with is patients with hereditary renal cell carcinoma, but patients can also have sporadic de novo tumors, satellite lesions from a single tumor, and intrarenal metastasis. Because of the association between multifocality and hereditary kidney cancer, the identification of multifocal RCC should trigger an evaluation for hereditary kidney cancer. This should include a detailed personal history of age of onset of kidney cancer and any past diagnoses or interventions. Additionally, it should include a family history of RCC. The patient should be questioned for other manifestations of RCC syndromes. Because of the cutaneous manifestations in some syndromes, a skin exam is recommended. And one may consider germline testing if appropriate. And so what is appropriate? And in our experience at the NCI, we evaluated 207 patients without evidence of, or I should say without a pre-diagnosis of a hereditary syndrome. And we found that patients with bilateral and or multifocal RCC, seen in the Venn diagram in the upper left, had an overlap with patients with either early onset RCC or patients with a family history, what we call familial renal cell cancer. Furthermore, the more of these features that patients had, the more likely they were to have a positive germline test. So in patients with no risk factors, germline tests were positive 7% of the time. But with one factor, over 12%, with two factors, 21%, and with three risk factors, 70% had a germline pathogenic variant and a gene known to be associated with kidney cancer. Going back to multifocal RCC, traditionally, the literature has reported there's a high rate of, quote, local recurrences after nephron sparing surgery, upwards of 50%. And this could be because of persistent disease not removed at surgery or de novo lesions that grew after surgery. And because of this, multifocal RCC has been treated more commonly with radical nephrectomy, despite similar cancer-specific survival outcomes seen between partial and radical nephrectomy. And in my opinion, it's been overtreated with radical nephrectomy. But what we call kidney cancer is not a single disease. It's a dozen different diseases that all arise in the kidney, all associated with different histologies, driven by different genes, and all of which have different natural histories and biologic potentials. You can see the genes associated with these histologies on this slide. And even taking out clear cell RCC to focus on non-clear cell, the topic of this discussion, there are multiple diseases really that are represented here. And because of that, I'm going to focus on the most common non-clear cell RCC, which is papillary type 1, which is seen in 15% of kidney cancer cases. So papillary type 1, you can see the histology on the right. It's associated with a fibrovascular core and these papillary proliferations. Papillary RCC is associated with multifocality, and in 37% of multifocal cases, they were papillary in a series from Memorial Sloan Kettering. It is the most common multifocal tumor in patients without a hereditary syndrome. That being said, it is associated with both sporadic and hereditary forms. Papillary RCC also has a higher incidence in Black patients versus white patients. As I mentioned, the overall incidence of papillary kidney cancer is around 15%, but among African American patients, that incidence goes up to over a third. And in white patients, slightly less than the 15% overall at 13.8. In management of the common sporadic form of papillary RCC may be inferred from the management of hereditary forms. And the hereditary form of papillary type 1 kidney cancer is called HPRC, which stands for hereditary papillary renal carcinoma. So HPRC is a rare hereditary form of kidney cancer with less than 50 families described in the literature worldwide. It's associated with early onset, bilateral, multifocal, and recurrent papillary type 1 RCC. On the image on the left, you can see a CT scan demonstrating multifocal and bilateral renal tumors. These were resected and were all type 1 papillary RCC. And you can see a pedigree from one of our early families at the NCI on the right. HPRC is associated with germline alterations of the MET gene. MET is located on chromosome 7, and MET can be altered. You can also have duplications of the MET gene and of the entire chromosome 7. HPRC is the MET alterations occur in the tyrosine kinase domain of MET. Normally, MET is activated by hepatocyte growth factor, which causes phosphorylation of the tyrosine kinase domain, which then has downstream pathways that it activates. But in HPRC, MET is constitutively activated, and these pathways are turned on all the time and lead to the manifestations that I previously described. The surgical management of HPRC-associated renal cell carcinoma is that we perform active surveillance for small tumors until they reach 3 centimeters in size. And once they reach this so-called 3 centimeter threshold, or this 3 centimeter rule, tumors are removed, and in fact, all ipsilateral tumors are removed at that time. When we perform surgery for these types of lesions, we often perform enucleations, and we don't clamp the kidney, and this is to really preserve renal function. And here's a short clip of a surgery in which we do that. This is via a retroperitoneal approach. We identify our tumor and really identify an enucleation plane where we can push the normal parenchyma away from the tumor, taking very little margin to preserve nephrons. And you can see these are nice, well-encapsulated tumors. And when performed in an enucleation plane, there's very little bleeding associated with this, even without clamping the renal hilum. So despite the rarity of HPRC, in the 43 patients that we've managed surgically at the NCI, we've noted that no patient has developed metastatic disease when the largest tumor size was less than 3 centimeters. As you can see, with larger tumors, there is an increasing incidence of metastatic disease. And so for patients with T2 tumors, those above 7 centimeters, the incidence of metastatic disease approaches 40%. In sporadic papillary kidney cancer, there are also often activating mutations in MET. In fact, in 15% of sporadic papillary cases, there are activating mutations, and with MET fusion or splice variants in another 5%. Duplication of chromosome 7 is seen even more commonly, with 50 to 70% of all papillary kidney cancers having a duplication in chromosome 7. And not only is MET located in chromosome 7, but its activating ligand, hepatocyte growth factor, is also located on chromosome 7. So duplication of chromosome 7 can lead to, again, constitutive activation of the MET pathway. Interestingly, in patients with multifocal papillary RCC, it seems that these tumors arise independently. So in this study from Jones and colleagues, 21 cases of papillary RCC that were multifocal were analyzed for a variety of different polymorphic markers. And in almost all cases, 95% of them, they did find patterns of allelic alterations. However, in most cases, there was not concordant allelic loss between tumors from a single kidney. In fact, in only one of 21 cases did these tumors seem to be of the same clonal origin. So this may hint that there is something, there may be some other type of hereditary predisposition or environmental factor that causes these tumors that's yet to be elucidated. Because of this pathway, the MET pathway in papillary type 1 RCC, it does open the opportunity for therapeutic interventions. This is a study from a few years ago looking at a dual inhibitor of both MET and VEGFR2 called feritinib. And this was a collaboration among multiple institutions and led by Dr. Ram Srinivasan here at the NCI. And of the patients in this study, the overall response rate was 13.5%. However, when looking at germline MET alterations, that was only 10 of the 67 in this study, but among those 10, 50% had a partial response, and of the other 5 had stable disease, and 4 of those had greater than 10% reduction in the sum length of the diameter of their tumors. So there seemed to be more activity among patients with MET alterations versus those with papillary kidney cancer who did not have MET alterations. In a more recent study, this was presented at ASCO. This was a phase 2 study of a different MET kinase inhibitor called INC280 or INC280. This was also led by Dr. Srinivasan. And among all patients with papillary RCC, I'll direct your attention to the large box in the center. The overall response rate was similar to feritinib at around 15%. However, in patients with a MET alteration, in this case, usually a mutation, the overall response rate was double at 30%. And it was noted that INC280 has acceptable toxicity profiles. And again, these were patients with localized disease. There have also been a number of studies looking at MET inhibitors in patients with advanced disease. There's similar findings with patients with MET alterations generally have a better response than those without. But in the context of multifocal RCC, this talk, it's a bit beyond the context of this talk. So in summary, I would like to leave you with a few items. One, multifocal RCC is a common entity. If you treat kidney cancer, upwards of a quarter of your patients may have multifocal RCC. The workup for multifocal RCC you should evaluate for hereditary kidney cancer syndromes. This doesn't necessarily mean germline testing, but it could if the patient meets the provider's threshold for testing if they have other risk factors. Oftentimes, radical nephrectomy will overtreat multifocal RCC, particularly when lesions are small. As we showed, the metastatic potential of these small lesions are quite low. And finally, emerging therapeutics may play a role in treating multifocal RCC, specifically in patients with MET-altered papillary RCC. Again, thank the KCA and the IKCS for allowing me to speak today, and I look forward to the panel discussion discussing non-clear cell RCC. Thank you very much. I'd like to acknowledge just briefly the team at the NCI. We're led by Dr. Marston Linehan, who is really has done so much in the field of kidney cancer genetics, And I'm lucky to work with Ram Srinivasan, a medical oncologist who's led 2 of the trials that I discussed today. And we have a host of other team members that really make our work here possible. Thank you again.